Hey guys, my name's Greg, and I want to talk to you today about how a paramedic recognizes and manages a difficult airway. Maintaining a patent airway is one of the most important things that a paramedic can do. If the patient can't breathe, then systemically the body is going to start shutting down from lack of oxygen. It's called hypoxia, as you guys well know. Today I'm just going to start with showing you just some simple methods first. The first thing we would do on a patient is you're going to check the airway to make sure it's not occluded, it's not blocked, doesn't have any teeth, blood, vomitus in the airway itself. If that would be the case, then you would get suction it out. I'm going to look at some mnemonics to see if the patient has a difficult airway. Does he have a short neck, a short mandible? Does he have dental problems? Something that's going to keep me from managing the airway in a positive way. I need to be aware of that stuff up front before I RSI. One of the key things you need to remember when addressing patient airway is never take away something from the patient that can't be replaced. If the patient is breathing spontaneously and you take that away by RSI, meaning rapid sequence intubation, where you're going to paralyze the patient, taking away all their natural spontaneous drive to breathe, you need to make sure that you've got a way to manage the airway, because once you take it away, you're it for the patient. The first thing we're going to do is just a simple nasal non-rebreather. This is a non-rebreather with an oxygen reserve. We're going to hook it up to our oxygen tank at 15 liters a minute. We're going to put that on the patient, and if the patient is oxygenating well with that and shows no signs of deteriorating and can guard their own airway, then we're going to leave that. If the patient is not adequately perfusing with that non-rebreather, then we're going to go to the bag valve mask. This is something that you need to look at and recognize in the difficult airway protocol. The thing I want you to think about in my report is, can you ventilate this patient with a bag valve mask? Signs to look for that you might not be able to ventilate are, do they have facial hair? Does the patient have a beard? Anything that's going to prevent this mask from sealing properly on the patient's mouth where you can ventilate. We don't want leaks coming out. So look to see, are there any deformities? Is there any reason that I'm not going to be able to bag valve mask this patient and take control of his airway if I RSI him? Once we moved from the bag valve mask, if the patient is ventilating with a bag valve mask, we want to put an OPA in, an oropharyngeal airway. And what this is going to do is you insert this. If there is no gag reflex, what this is going to do is this is going to allow the tongue to be kept out of the back of the oropharynx, and it will not occlude the airway. And then that way you're going to get a patent airway with the bag valve mask. Once again, if your patient is ventilating properly with the bag valve mask, then you need to question, do I really need to RSI this patient? Is there indications to go ahead and intubate this patient? If there are indications to intubate this patient, then the next step we're going to do is you're going to have two paramedics on site. One is going to continually ventilating your patient while the other draws up your medications. Once we've administered medications and we have paralyzed and sedated our patient, then we're going to perform the rapid sequence intubation and insert the intubation tube. What you're going to do is you're going to take your laryngoscope, and you can see how all this stuff has to be in order. If you're chaotic and stuff's not in place, you got to remember this patient is not breathing. So if you just wanted to do a little test at home, hold your breath while I'm doing this and see how long that it takes you to become uncomfortable. Well, your patient, even though he's unconscious, he's perfusing the same way. If he doesn't have an airway, then he's starting to become hypoxic very quickly while you mess with the laryngoscope, while you get this, while you get that. So you really need to be proficient. You need to be everything in order. So once I've hyperventilated my patient, and what I'm going to do is I'm going to make sure all my tools are ready. I've got my laryngoscope, I've got my ET tube with my stylet, and then I've got my 10 cc syringe. This is the old style laryngoscope with the Mac blade. You want to make sure the light's working. And then what we're going to do is once we've hyperventilated the patient, he is paralyzed, sedated, then I'm going to introduce this to the right side of his mouth. I'm going to sweep the tongue to the left. I'm going to visualize for the glottic opening, and then I'm going to insert my tube through the glottic opening, past the vocal cords. I'm going to pull my stylet. I'm going to inflate my bulb syringe, and then I'm going to take my bag valve mask, all the while holding to my ET tube, and I'm going to ventilate. The first place I'm going to listen for correct placement of the tube is in the epigastric area. I want to make sure I have no sounds there. That means I'm not in the stomach. And the next place I'm coming is I'm going to listen for breath sounds in the lungs. I'm going to confirm lung sounds bilateral. Bilateral because I want to make sure my tube is not so far down that it's gone down the right main stem of the bronchiole and only inflating the right side. So once I see equal chest and rise on the patient, then I know that I'm placed. The problem is with a difficult airway, you see this kind of went pretty smooth, but the difficult airway, and why a paramedic needs to be aware of that, is, for example, say I didn't recognize that this patient maybe had a Mallampati score. Mallampati scores are you can look in the back of the throat, and the anatomical landmarks that you can see that are visible gives you a Mallampati score. 1 is good, you have plenty of sign. 2 is not so good. 3 is worse, and 4 is almost no signs at all. Basically, you can't see anything in the back of the throat. So, say I'm a paramedic and I'm not paying attention to my patient, and maybe not noticing that a bad Mallampati score, or he's got a beard, and I get carried away in RSI, and now I've taken away his spontaneous breathing response, and now I can't mask him. I can't bag him. He's not breathing, so I try to get my laryngoscope, and I come in here. Now the patient's not breathing. He's not breathing. He's not breathing. I come in here, and all of a sudden now I can't find an airway. I can't see the airway. I can't see the glottic opening to replace because of anatomical deformities. Maybe the mandible is short. Maybe his teeth are in the way. For some reason, I can't pass a tube. So my patient now is not breathing. So now what do? I've gone ahead and created a mess for myself. The difficult airway is something one anticipates. That's me anticipating this is going to be difficult because of his landmarks or his anatomy. A failed airway is something one experiences. Now with this patient, I'm experiencing a failed airway because I've gotten in such a hurry. I didn't take my time and evaluate the difficulty of the airway. Now I've got a failed airway. I've taken away any spontaneous breathing he's got. I can't pass my tube. What do now? Well, as a paramedic, I've created a situation now where I have got an option to do a cricothyrotomy. And basically, I'm going to come down to the patient's larynx. I'm going to find a thyroid cartilage. I'm going to come on down and find a cricoid ring and feel the membrane, the little notch right in between. When I have located that, I'm going to take my scalpel and I'm going to make a horizontal incision through the epidermis. Once I've made that, then I'm going to take my spreaders and I'm going to spread that open until I see the cricothyroid membrane. Once I see the membrane, then I'm going to make an incision through that into the trachea. I'm going to take my spreaders once there and I'm going to spread this open. At that point, I will take an ET tube size 6 and I'm going to insert it right in the trachea this way. And then once I do that, I'm going to inflate my cuff, and now I have got an airway. And now my patient is ventilating. Just how long did that take? That's a long time. It's all because that as a paramedic, I failed to realize the difficulty of the airway of my patient. I've gone from preparing and managing a difficult airway and taking time to rushing, being unprepared, and creating and experiencing the failed airway. Now I've had to make an incision in the guy's throat and go in this way, whereas before, if I would have just taken my time and realized, I could have saved a lot of pain and a lot of effort just by being prepared. There are a lot of new technologies on the market, as you guys know. The glide scope is coming out, and I have seen it in hospitals. I'm sure you guys have seen that. But as far as it's coming out to replace the laryngoscope, in my opinion. The glidoscope, the laryngoscope, you have to have head position. You're trying to get the glottic opening in line where you can see with this visually with your eye. The glide scope actually has a camera on the end, so as you're inserting the glide scope, what you're seeing in the back of the oropharynx is coming up on a screen. So there's no reason to manipulate real hard. When you enter in, you can kind of move your hand and see the glottic opening and then pass the tube. It takes a lot of the difficult airways out of play because you don't have to have the visualization of the vocal cords to pass the tube through. You're actually visualizing it through the glide scope. The bougie is also a new technology, and basically the bougie is a 5mm nylon cord that can come up to 70 centimeters in length, and the bougie is a stiff cord that you'll actually insert into the patient's oropharynx, into the glottic opening, and then you're going to take your ET tube, once you've found the glottic opening with the bougie, then you're going to slide your ET tube down over the bougie, and it's going to act as a guide for you to slide down into the glottic opening. Both of those things are latest, greatest technologies in the area of airway management. One thing I want to say in conclusion, can the patient breathe? The most important reason a paramedic needs to be able to recognize a difficult airway and to treat it is for the oxygenation of my patient. They're in your hands. It's very easy to realize why you need to know how to manage an airway. The result of an unmanaged airway is death, and nobody wants that. So I hope you guys have learned a little bit. I hope it's been informative. Anything from the simplest non-invasive measure all the way up to the most advanced we have. Remember, just be a good EMT to start with. Then if you need to go to the next level, then be an intermediate. And then if that doesn't work, then you can always go to the paramedic level as far as treatment. I always like to do the minimal invasive maneuver first and then go to each level depending on what my patient needs and what's the best outcome for them. So I hope this has been informative for you guys. Remember, try to manage the airway, realize your difficulties up front, and hopefully the difficult airway is something you're going to recognize and not experience the failed airway. Thank you so much for your time. Have a great day.